Are you locked?
I was born locked, bro. All right, guys, welcome back to Strudel Med Student Reviews. Here we have our hematology review today. Very high yield topic, a lot of stretching in between the systems, very similar to renal. You'll see it in a lot of different shelf exams. There's a lot of ways they can test it. So the first part of this video, kind of to lay out the general format. The first section of this video will be mostly background information, things that are required for you to know so that you can better understand the back half once we get into the cases. So just hopping directly into it here. So primary hemostasis. Very high yield to know that the first step in primary hemostasis is endothelial injury. No matter what the cause is, whether that's oxidative damage or atherosclerosis or actual trauma to the vessels, whatever the case is, endothelial injury also can be caused by glycosylation of proteins and diabetes, all these things. Endothelial injury is very high yield as the first step. And then our first big interaction is that we have von Willebrand factor binding to exposed subendothelial collagen and very high yield, especially for the purposes of step one. Von Willebrand factor coming from the Weibel-Palade bodies or the WP bodies of endothelial cells, of the vascular endothelial cells. There's also some of it in the alpha granules of platelets. So that's our first interaction to know. So von Willebrand factor binding subendothelial collagen. From there, now we have the platelets binding von Willebrand factor via an interaction between GP1B, which is on the platelet surface. So that's our next big interaction is with GP1B, platelets binding to von Willebrand factor. After the platelets bind von Willebrand factor, the platelets go through that conformational change that we have noted there, and they release a bunch of mediators. Some of those, the most high yield ones of them being ADP, calcium, and thromboxane A2. So very high yield to know these mediators and now kind of how they'll interact. So ADP specifically, very high yield binds the P2Y12 receptor to induce GP2B3A expression on the platelets. So now the initial platelets after binding VWF via the interaction with GP1B releases these mediators, and those mediators act to activate other platelets. And one of the main ways that that is done is by ADP binding the P2Y12 receptor and inducing this expression of GP2B3A. And then finally here, fibrinogen is able to bind GP2B3A, and then this will end up cross-linking multiple platelets together and providing the basis of coagulation, which is the weak platelet plug, otherwise known as the white thrombus. So just in general, going from that background information, very high yield to know the receptors and the mediators involved. So in general, what kind of favoring factors for aggregation do you think of, Mike? Just after that little talk on the mechanism.
So the first one that I think about is endothelial injury, which is actually typically kind of required for hemostasis to occur. And then some factors that are very high yield to know are thromboxane A2 or TXA2, which favors aggregation, and then any reduction in blood flow or stasis or non-laminar blood flow.
Very good. So kind of going back to like our general coagulation of blood, anytime there's reduced blood flow or the laminar flow is disrupted, there's increased stasis of those factors and things are more likely to stick together. And then thromboxane A2, we'll mention very soon, a very high yield way to kind of stop thromboxane A2 from favoring aggregation and therefore kind of being an antiplatelet agent. We'll kind of get there in a second. So now in the opposite vein, factors preventing aggregation of platelets. These are going to include things like PGI2, nitrous oxide, and then in the opposite way, increased blood flow or better, smoother laminar flow. Those things will keep everything moving appropriately. There will be less stickiness, and you can expect less aggregation of platelets in those settings. So tell me what stabilizes the platelet plug, Mike. So we went through all this process, steps 1 through 6 up there, and now we have this white thrombus or this weak platelet plug. Now what?
So now that we have the platelet plug, which is the end product of primary hemostasis, then we move on to secondary hemostasis, or everyone's favorite, the coagulation cascade.
Very good. So yeah, so we're going to go into this secondary hemostasis, the coagulation cascade. But before we get into it, I know everyone's eagerly awaiting our talk on the coagulation cascade. Let's talk quickly, very quickly about the antiplatelet agents. So probably most high yield of all, aspirin. Mike, tell me what you know about aspirin.
So aspirin is an irreversible inhibitor of cyclooxygenase 1 and cyclooxygenase 2. So that means there's typically, at least a 10-day washout for aspirin because that's how long cyclooxygenase takes to replenish. So that would prevent the synthesis of thromboxane A2, which would basically be reducing a pro-aggregation factor. So that means that aspirin would lead to less aggregation of platelets.
Very good. And we had also kind of mentioned thromboxane A2 is also kind of a vasoconstricting agent. So this would also lead into less vasoconstriction, but very high yield to know, an irreversible inhibitor of COX-1 and COX-2. So good to know that. Moving on to like kind of the next step in the cascade, agents like clopidogrel or Plavix, prasugrel, ticlopidine, also ticagrelor or Brilinta. What's our mechanism there, Mike?
So the mechanism of these is another antiplatelet agent, but this time these agents bind on the ADP receptors, the P2Y12 receptors on the platelet themselves. So that would prevent the necessary binding of the ADP with the P2Y12 receptor, which is necessary for activation of GP2B3A.
Perfect. So as you can see there, once again, irreversibly binds P2Y12 or the ADP receptor on the surface of the platelets. That's going to prevent them from going through and expressing that GP2B3A complex, which eventually could bind fibrinogen. So you're never going to get to that point. So the platelets are going to be less able to cross-link in that case and less able to find to form that platelet plug. So then kind of lastly, going further down, we have these medications here with weird names. So abciximab, obviously a monoclonal antibody, eptifibatide, and then tirofiban. All of those are different mechanisms. So what's that one, Mike?
So these are GP2B3A inhibitors, so another antiplatelet down the pathway of primary hemostasis. And it's just high yield to know that integralin, which is the eptifibatide, is can be used as an IV drip. So in patients who have nausea or vomiting, you can administer an antiplatelet through the IV.
Also, just a really quick hitter. I mean, first, before I get there, aspirin and Plavix are by far the most common that you will see on this list. We use them all the time in the hospital. But can you tell me a very high yield side effect of ticlopidine, Mike? It might get asked about on exams.
So that high yield side effect is agranulocytosis.
Very good. Yeah. So if you see a patient recently has had a reason to be put on an antiplatelet agent and now presents with leukopenia, maybe an atypical infection or something to that nature, be thinking about ticlopidine. They like testing that on exams. All right, so now the long-awaited discussion of the coagulation cascade. So in this video, we're not going to try to go super duper in depth and spend a whole bunch of time on this because we know the cases take priority in our review session here. So just hopping right into it, talking about the intrinsic cascade, that's going to be the one that's up in blue on this diagram here. So here's our order of that. 12 getting activated to 12A, then activating 11 to 11A, 9 to 9A, and then activating 8 to 8A before getting into the common pathway, which starts with 10 and then down to 5, 2, and then 1. So multiple ways to remember it. We'll go into that in just a second, but it is also kind of high yield to know that activated thrombin or factor 2A also can activate factor 13. So there are different ways to remember it. The way I was taught is with the mnemonic tenet being like T for 12, E for 11, N for 9, E for 8, and then T for 10 again. But you can also just count down from 12 to 12, 11, 9, 8, and then 10, knowing that 10 is the basis of the common cascade. So it doesn't get featured earlier on. It's the last one. So Mike, how do we go about measuring the activity of the intrinsic cascade?
So that would be with the APTT. So it's PTT is 3 letters, just like the abbreviation of heparin is HEP, which is also 3 letters. So I remember intrinsic pathway, PTT, and that also is for heparin. And then one thing to note about factor 13 is your um, fibrin stabilizing factor. So that's necessary to kind of cross-link fibrin.
Very good. Yeah, so how we're measuring is the APTT. So we'll go into the kind of application of that, but very important to know that. And then now the extrinsic pathway, as you can see over there in the red portion of our diagram, factor 10 being, or factor 7, excuse me, being activated by exposure to tissue factor, and then with calcium working together to activate 10 to 10A. So how do we measure the extrinsic cascade, Mike?
So that would be with the PT, and this would be for drugs like warfarin. It's the PT is also called the INR.
Yeah, very good. So yes, PT is how we would measure it. The INR or the normalized ratio is basically comparing a patient's PT value to kind of an age or demographic matched normal value, and then seeing like how thin or how less likely to clot is a patient's blood compared to the average person. So there's kind of our overview of the coagulation cascade. And now we'll kind of go into kind of more of the application of that. So with our anticoagulants here, I know, Mike, this is a topic near and dear to your heart, being a native Wisconsinite, Wisconsinian, whatever you call yourselves.
So warfarin was originally actually a rat poison, and the mechanism of that was basically super therapeutic levels of warfarin cause excessive blood thinning in rats, which would lead to its use as a rat poison. But the way it does that is as an epoxide reductase inhibitor, and epoxide reductase is an enzyme that's necessary in the liver to essentially activate vitamin K. So by losing the activation of epoxide reductase, then vitamin K isn't able to be active.
Absolutely. So we have an epoxide reductase inhibitor. Sometimes it's also mentioned as like a VCORC1. That's like the enzyme abbreviation inhibitor. We're going to stop the gamma carboxylation of specific clotting factors. And then, yes, obviously that history being discovered in Wisconsin, used as a rat poison. So what factors are affected by warfarin, Mike? Both factors and associated proteins.
So the way I always remember what factors are affected with warfarin or Coumadin are, I imagine like a basketball player, like someone like that is kind of the star of the team, like LeBron James or Giannis, if we're sticking with Wisconsin. So I think of them having a near triple double. So that's like 27 points, 9 rebounds, 10 assists. And that helps me remember that it's factors 2, 7, 9, and 10, and then proteins C and S as well.
Perfect. So knowing that 2, 7, 9, and 10, along with protein C and S are um, affected is very high yield because there will be several questions about this, and it also goes into why we measure it and monitor it the way we do. It's also kind of high yield to know that you need routine INR measurement and titration. So this makes warfarin kind of an inefficient or an inconvenient, I should say, medication to have on board on a patient. Sometimes it's your only option because we have data supporting it for certain uses, but it does require some extra care to make sure that INR doesn't get too high and the blood isn't too thinned. It also has a lot of interactions with different foods and other medications as well. So how do we reverse warfarin, Mike? And let's say we're not in a rush today to reverse it.
So if we're not in a rush, then the kind of the medication to consider would be, if we think about what warfarin's doing, it's essentially inactivating or nullifying vitamin K. So we would give vitamin K to reverse the effect of warfarin.
Awesome. Yeah, so we're going to do vitamin K if we're not in a rush. Now let's say we are in a rush. So we have somebody with an acute bleed somewhere. We need to reverse it now.
So then this would be a consideration for FFP or fresh frozen plasma, or otherwise cryoprecipitate or PCC.
Yeah, very good. So PCC or prothrombin complex concentrate is now usually the right answer on exams. For a long time, it was FFP to replace those factors, but PCC is actually considered the better agent now. So on exams, at least, if you need to reverse warfarin in a hurry, go for prothrombin complex concentrate or PCC. So now, Mike, a different kind of scenario for you. You have a patient with a good reason to be on warfarin. So let's say they have like valvular AFib or something like that, and you are getting ready to start them on that before they leave the hospital. So this requires something called bridging. What do we use to bridge, Mike?
Yeah, so some good indications for warfarin still are, as you mentioned, valvular AFib, or also any mechanical valve. The INR for a mechanical valve is a little bit higher. So typically With something like atrial fibrillation, you would want the INR to be between 2 and 3. But with a mechanical valve, then typically we aim for the INR of 2.5 to 3.5. And something we bridge with or we start while we are initiating warfarin would be something like a heparin or a low weight molecular heparin like enoxaparin.
Perfect. So either heparin or heparin's derivatives, which is the low molecular weight heparins, such as Lovenox. So that is very high yield to know, and we'll have a case here in just a bit. But which factor affected by warfarin has the shortest half-life?
So the factor with the shortest half-life is factor 7.
Perfect. Yeah. So Factor 7 having the shortest half-life also means it's the first one that's going to show evidence of being inhibited by warfarin. So that's kind of how I justified in my mind that we track warfarin with the PT value, looking at the extrinsic cascade, which relies very much on the activity of factor 7. So just kind of drawing that connection in your mind is also good. So why do we bridge, Mike? What happens if we don't bridge? At least on exams, what happens if we don't bridge?
Yeah, so if we don't bridge, then there's a significantly increased risk for warfarin-induced skin necrosis. And the other thing to mention is we do track the PT-INR, both because factor 7 is the shortest half-life, and while warfarin affects both the extrinsic and intrinsic pathways because it affects the common pathway affecting factor 10, heparin does not affect the extrinsic pathway. So that's why we also use INR as a measure for
Good. Yeah. Very nice. So the reason for bridging, why we do it is because we get this case of warfarin-induced skin necrosis. So the etiology of this, and Mike actually kind of alluded to this earlier. So protein C along with protein S, specifically in this case, protein C has a shorter half-life than the factors. So that means when you initiate warfarin, the actual first thing that's going to happen is that you're going to have inhibition of protein C gamma carboxylation, which means without protein C, which is actually an antithrombotic factor or an anticoagulant factor, or an anticoagulant substance, I should say, more so, you'll actually be hypercoagulable in that small window. So how that will present is usually with a necrotic patch of skin somewhere that's caused by a by like superficial thrombi forming due to this paradoxical hypercoagulable state. So very high yield to know that the reason why that is because protein C will actually be affected first, and therefore you'll be hypercoagulable for a short period of time there. So moving into this is not kind of a question and answer thing. This is something kind of to more make you guys aware of the different scenarios they can test with warfarin. So one of the big things with warfarin is obviously, like we've mentioned multiple times, is checking the INR. So what do we do when the INR is higher than we'd like or super therapeutic? So, firstly, we have this case. A 70-year-old male on warfarin is diagnosed with a hemorrhagic stroke. And how would we manage it? So, he has an acute bleed, and we already talked how we would reverse emergently. You still give vitamin K, but the key is that you give PCC or prothrombin complex concentrate. And obviously, you're going to hold warfarin in that case. You wouldn't want to keep giving them warfarin. So, 50-year-old now on warfarin found to have an INR of 6 sometime in the clinic on a routine check, but they're not displaying any signs of bleeding. You can't really pinpoint any symptoms of that. Their blood counts look okay. What's your management there? Well, in that case, you'll just hold the dose and you'll recheck the INR in about 48 hours. So, really high yield to know that it's elevated. It's super therapeutic, like we mentioned. Typically, we're going to see 2 to 3 be the therapeutic range. If you have a valve, then you're going to have 2.5 to 3.5. So 6 is truly elevated, but it's not super duper elevated, specifically not greater than 10. So in that case, we can just hold the warfarin and recheck the INR here in a couple days. Now, in opposed to that, you have a 60-year-old male on warfarin, and his INR is 12, still not displaying any signs of bleeding. So how would you manage it now? So in that case, not only are we going to hold warfarin, but we're going to give a dose of vitamin K as well. So that's high enough where the risk of bleeding is starting to get up there. So we can kind of hasten the INR return back to therapeutic range by giving vitamin K. So we'd give vitamin K there, and then we'd recheck the INR in a certain amount of time, whether that be in like 24 to 48 hours. We say about 48 because that's usually when the labs start to actually show a true difference. But if you were really worried about somebody, if they had a history of bleeding or what have you, you could probably check that sooner. So good to keep in mind, this is the kind of the main scenarios with warfarin. Know how to reverse an acute bleed. Know that when it's just a slightly elevated INR, that you can just hold it and recheck. And then know that if it is above 10, you can give a dose of vitamin K to kind of hasten that return back to therapeutic range. So good to know those little scenarios there.
One more thing, Tate, that I'll ask you a question is,
Sure.
let's say we have a patient that is on warfarin and their INR was typically in, the therapeutic range between 2 and 3. Let's say they're on it for atrial fibrillation, but all of a sudden their INR is actually subtherapeutic, like 1.5. What kind of changes to their diet would you
Oh
think
yeah.
of that may have caused that?
So this would be kind of a case like they're reversing warfarin on their own. So that means that they're eating a large amount of vitamin K somehow in their diet. So usually when they ask about this is usually something like leafy greens, stuff like kale. Maybe they went on a giant, I don't know, kale kick for whatever reason. And they've eaten enough vitamin K, consumed enough vitamin K to effectively reverse their warfarin.
Yep. And then another one to know is grapefruit.
Yeah, grapefruit specifically is because the grapefruit juice has an effect on the cytochrome P450 system. So that one's to know that it's more about the enzyme breaking down warfarin rather than about the vitamin K mediated mechanism. So in general, grapefruit juice is good to think about. Also, this is why warfarin is kind of dangerous. There are a lot of medications that affect cytochrome systems, and some of those can make the INR very difficult to control. So very important to note that if you do have like a cytochrome inhibiting or inducing medication, you probably would not want to give warfarin to that patient as well. So good
Yeah.
things to kind of keep in mind.
The other thing to kind of know is it's also renally cleared. So in patients with, suddenly impaired kidney function or on dialysis, warfarin can also be difficult to manage in these patients, and warfarin toxicity can actually be an indication for dialysis.
Very good. So kind of working our way into the more of the anticoagulants. So this is good old-fashioned heparin here. So what's our mechanism of action of heparin, Mike?
So heparins are actually naturally occurring proteins in the body for most people. And what heparins do normally, or kind of heparin binding proteins, is that they bind to AT3 or antithrombin 3, that thereby, and that's how heparin exerts its effects, because antithrombin 3, when activated with heparin, can inhibit many factors like factor 2, 7, 9, 10, I think 11 and 12 as well. So almost all factors in the coagulation cascade.
Perfect. So yeah, knowing that heparin specifically enhances the activity of antithrombin 3 and are going to inhibit that long list of coagulation factors there. Also very high yield to just kind of keep in mind about heparin. It has a very short half-life. You can give it as an IV drip, and you'll monitor it with PTT, usually based on a protocol or an order set in most EMRs nowadays. So this is stuff that the nurses will constantly be checking the APTT and then titrating the heparin as needed to get a certain therapeutic threshold, depending on the situation that you're in. So good to know that. And
Yeah.
like you'd mentioned, how do we clear it?
Yeah. So this is actually cleared through the liver. So it's hepatic clearance. And one thing to know is that we do monitor PTT for heparin, but newer order sets and newer evidence actually uses anti-10A to measure heparin therapeutic dosing.
Yeah, I have actually heard that. That's a good point. And that might actually become more testable. So yes, hepatic clearance. And how do we reverse heparin? Very high yield to know.
So heparin is negatively charged. It's a negatively charged molecule. So there's a molecule, protamine sulfate, which has a positive charge that's actually from salmon sperm protein that can be given to rapidly reduce at least full weight molecular heparin.
Absolutely. So protamine sulfate, positively charged molecule. Good pimping question that it's from salmon sperm. Um, and yes, it reverses and it does help mostly with unfractionated heparin. So good to know that as well. So then we move into dalteparin or enoxaparin, which is Lovenox that we'll see very commonly. So these are the low molecular weight heparins. They act more on factor 10A, but they also do kind of do the same mechanism of enhancing antithrombin 3 in its function. Very nice. Along with heparin, it can also be given sub-Q. And this is kind of how we'll see it most with its main use in the hospital as VTE prophylaxis. So good to know that. And then how is it cleared?
This one is renally cleared. So this is important because inpatient, patients that require DVT prophylaxis, low weight molecular heparin like enoxaparin is a good option, but it's important to check or know their kidney function to know the appropriate dosing or if enoxaparin is a good option for them.
Absolutely. So keep an eye on the renal function with Lovenox. And then reversal agent, like I mentioned before, you still go for protamine. It's just not as effective as with unfractionated heparin. Heparin is unfractionated heparin, excuse me, is preferred in a lot of situations because it technically has a very quick on off. You can give protamine and reverse it very rapidly. So it makes it very dynamic and very easy to kind of work with that way. It's just been around a long time. So a lot of people are very familiar with how to kind of manage heparin. So it's used quite a bit.
One other thing is that with very low weight molecular heparin too,
Fondaparinux would be that one.
yeah, so that one basically acts exclusively on 10A. It's not used as often, but it's also another heparin.
Good. Yeah, so just kind of think of it on a spectrum where heparin is basically full on antithrombin 3, and you get a little bit more activity on 10A as you go down in molecular weight, if you will. So keeping that in the back of your mind is good as well. There's our image of what the heparin binding group looks like, and then obviously somebody giving it subcutaneously like you would give Lovenox. So good to know. Okay, so just to kind of finish up, or at least part of um, the anticoagulants here, especially after talking about heparins, what's the big high yield adverse effect of heparin and sometimes its derivatives, Mike?
So the one that's commonly tested would be heparin-induced thrombocytopenia, in which heparin kind of acts as a hapten and basically leads to immune destruction of platelets.
Very good. So, heparin-induced thrombocytopenia or HIT, more likely to happen with unfractionated heparin, but it does happen every once in a while with low molecular weight heparin. And there are two subtypes. So let's kind of go into these, or historically, should I say, two subtypes. And type 1, what used to be known as type 1, is now kind of referred to as non-immune heparin-associated thrombocytopenia. So this is due to direct platelet aggregation that's mediated by these heparins. It usually happens within 5 days of administration, and it's pretty mild. It's not going to get you to a severe thrombocytopenia. What do we do if we notice this, Mike?
So for type 1 hit, then the best next step is kind of observation because it's a more mild form of hit.
Perfect. So yeah, exams love to test when to not do anything, and this is a great time not to do anything. We would just continue to observe. This is a self-limited process. So now, what was historically type 2, this is what Mike was talking about in immune-associated heparin-induced thrombocytopenia, where the heparin molecule acts as a hapten, and then later on, after use, usually somewhere in the period of weeks, you'll have this autoimmune response where IgG antibodies are formed against the heparin and platelet factor 4 complexes, and therefore will cause consumption of platelets and a pretty severe thrombocytopenia in this case. So we see that, Mike. What do we do?
So I've actually had patients with type 2 hit, and what we want to do there is discontinue heparin immediately. However, type 2 hit often occurs because it's an autoimmune response, actually several weeks after heparin was given. So, it could be a patient that had heparin in the cath lab, had a stent put in, didn't get any heparin after that, but then develops thrombocytopenia, 2 to 3 weeks after that kind of insult or receiving heparin. So make sure these patients aren't on heparin, but a lot of times they won't be on heparin, and then you want to admit them inpatient and complete evaluation because these patients are at a prothrombotic state. So you want to really look for any evidence of hemodynamic instability, hypoxemia that can make you worried about pulmonary embolus or any limb pain, both upper and lower limb pain that can make you worried about a deep venous thrombosis or DVT, and then basically immediately begin a valirubin or argatroban. And these can both be given. I believe argatroban can be given through the IV, and these will be your direct thrombin inhibitors.
Yeah, so a lot of good information there in what Mike just said. So obviously, first step is to discontinue the heparin if they're still on it. But like Mike said, a lot of times these patients will have been exposed to heparin, but not necessarily on it at the moment that they're getting it, especially these weeks after being administered it. So we're going to switch immediately to a direct thrombin inhibitor such as bivalirudin or argatroban. And that will kind of mitigate what Mike was talking about, how in this case they're actually hypercoagulable as well. So kind of a paradoxical state where you're kind of both hyper and hypocoagulable at the same time. Um, and then there's kind of new caveats how to diagnose. So, Mike, can you tell me how would you start the diagnostic workup, and then how would you confirm it if that first test was positive?
Yeah, so the way it used to be tested was that the best next step when you suspect uh, a hit and you've completed the initial diagnostic workup and the patient is stable is to obtain a serotonin release assay. But now there's actually a platelet factor 4 ELISA, I believe, that measures the antibody that can be used as an initial screening test, and then the serotonin release assay can be used as a confirmatory diagnostic test for type 2.
Awesome. So yeah, used to just be serotonin release assay across the board, but now if you're asked in the case where you think we have a legitimate type 2 immune-associated heparin-induced thrombocytopenia, next best step is going to be to discontinue heparin. If you've already done that, then you'll switch to either bivalirudin or argatroban. And if they ask you the next best step in diagnosis or best next step in evaluation, that would now be the platelet factor 4 serology testing confirmed by the serotonin release assay. So know that kind of all those different factors because there's a lot of ways they could ask this question. But first thing you got to do is know that they were exposed to heparin and now they have a thrombocytopenia either in the order of weeks where you actually have to go about treating it like type 2 hit, or is it in the order of days where you can get away with just observation? So anything to add there, Mike, before we kind of move on to the cases?
Nope, I think that was a good quick review of kind of some antiplatelets and anticoagulants.
Very nice. So yeah, have a good handle on those, and we'll kind of hop into these cases here. So here's a little summary picture. We already kind of had this up on one time. Knowing the differences between the intrinsic and the extrinsic, how we measure them, what factors are involved, and what anticoagulants are messing with both of those cascades is very high yield to know, and it's good. It's useful information both in real life and for testing, especially.